Hello, my name is Bolourani from Northwell Health. Thank you for allowing us to present our work, which is on using machine learning to predict failure of AV fistula maturation. I have nothing to disclose. So why do we choose this question? Because successful long-term hemodialysis is dependent on functional vascular access, and there is a growing body of evidence that has identified BMI, age, female gender, peripheral vascular disease, diabetes to be the risk factors for failure of AV fistula maturation. However, no consistent criteria is applied to identify this at-risk patients. So data that we used was from Northwell. We used 783 upper extremity AV fistula creations between 2014 and June of 2020, and we identified 143 failures. Features included genders, comorbidities, attributes, surgical history, type of fistula, whether endovascular interventions were applied or not, and ultravascular findings. We used two machine learning framework, one non-linear and one linear. XGBoost is our non-linear model, which is a tree-based model, which uses decision trees to make the prediction, and logistic regression uses sigmoid linear framework to make the prediction. We use a near-miss method, which is a trick by using our original data set by contracting the majority class, which is in our case, these blue dots are our successes. And by learning from these near misses, which is that they almost failed maturation, but they didn't. By learning from these, it has been shown to increase the sensitivity of the model. So this is how the models performed. XGBoost had the best prediction model. When we use near miss with XGBoost, our predictive ability has gone down a little bit, but logistic regression was the worst of all, which was slightly better than random. When we looked at the precision recall curves, that also followed the same trend. XGBoost was the most predictive, and XGBoost plus near miss was the second best. But when we look at specific criteria like accuracy, recall, and specificity, recall is another name for sensitivity, it shows that what near miss actually does is increases our sensitivity while decreasing our accuracy and specificity. So this has implication on why we asked the question. Among variable importances, which are the measure by which we identify which variables helped the correct classification of patient failure or success, among them we had size of the pre-op vein, history of CABG or angioplasty, female gender, age, and BMI to be among the top 10. So which model is the best one to use? Well, if recall is more important to us than precision, meaning that false negatives is much more costly than false positives, then we should use XGBoost plus near miss. However, in most clinical setting, the precision is more important to us than recall, because we would rather create fistulas and fail than don't create fistulas at all, which means false positives are much more detrimental. Then we should use the more precise model, which is XGBoost. Thank you.
An interesting topic. Practically, how do we apply this machine learning? Is this more for hypothesis generating or to confirm already how we do it, where as sort of clinicians, we bring in these variables, including things we sense on physical exam, on duplex, on their comorbid factors, to decide when we give the go to the dialysis center to start accessing it? How do you see this moving forward?
Thank you for the question. One way to think of it is these are the patients that clinicians have already decided that they will have a maturation of the fistula. So the failure rate is quite low. I would say that this can only be clinically used in a in sort of a borderline case where the physicians are not sure whether the fistula maturations would fail or not, and they just want to have another confirmation, because again, it's really difficult to have positive cases here, which for us it's failures, because the clinicians have already decided that this fistula would mature. That's why they did the fistula. And I would just say the best place to apply this would be on the borderline cases where, say, your pre-op vein size is 2 centimeter on a diabetic female, and then you're not sure whether the inflow is good enough. I would say just very borderline cases, which is why, again, like when you're looking at the our ROC curves also, it's not like 0.9, 0.8. This is around 0.7, which means like our prediction is not as good. Our sensitivities are not as good because they've already pre-selected by the clinicians. As you saw in the neural network, for example, they had a 0.9. That's because this is not already selected from the patient that are being tested. So it's a little bit it's a difficult question. Readmissions and things like this are very difficult questions to answer.
Yeah, it sounds like a lot of this body of work is going to rely on large data sets to confirm predictive models, and then it's only going to be as good as the data set it's derived from and whether it's clinically relevant. Past President Peter Nelson asks, does it make sense or make any difference to set this learning model to predict success rather than predicting failure? Is that a denominator numerator question, or does it matter?
So yes, if we were talking, so we are usually setting our positives to be a minority class. That's always true, even like for prediction models of COVID, for example, you're predicting mortality or respiratory failure, you're predicting a minority class. If you set your prediction to the majority class, which is most of the operations here are successes, that's not done in practice, and it would bring the specificity down a lot. The sensitivity down high, and then specificity down a lot. If we apply this to a different population, say not selected by clinician, just right after the screening was done on the ultrasound, and the clinicians have not decided, then we have a different question. Then the predicting successes would be prudent, because then that pre-selection has not been done already.
Right. No, that's why I was curious also whether in your group, I'm sure you have a large series of AV graphs where the clinician has already decided based on their biases, clinical exam, duplex findings, that they will go to a graft. And then maybe if you combine the models, then it becomes something more useful to use, and you can create some score or some app or something that you plug in all the info, and it gives you a ESPN likelihood of victory for a certain type of procedure.
If you look at that, means we have to make that assumption that if the graft is being done, it means that which is a good assumption, that the fistula was decided that it's going to fail.
Right. Okay. Thank you. Nice job. I'll turn it back over to Mark.